and we are very happy to have you here and hope we have some other new people. You can check out our website. We'll put it in the chat so you can go to it. But we'd love to have you think about joining us. And we do a webinar every month, and so I'm really interested in hearing what Sebastian Pois has to say about preconception care, and I know everybody who's on this call is. Before we start, I want to apologize on behalf of myself and many citizens in my country for what we are doing in the world. So it's dreadful, and I am sorry for all the damage it's causing in so many ways. It is my pleasure to introduce, so I'm Judy Lewis, I'm the board chair of Women in Health Together for the Future, and it's my pleasure to introduce Dr. Khalifa El-Musharraf, who is a founding member of this organization and also participated many years before that, and who is a very accomplished researcher in maternal health and the economics of healthcare for both maternal health and NCDs, and is the head of the public health programs at the University of Birmingham in Dubai. Khalifa, I turn it over to you.
Thank you very much, Judy. So good morning, good afternoon, and good evening to everyone joining us today from around the world. I'm Dr. Khalifa Al-Musharraf, the Director of Public Health Program at the University of Birmingham, Dubai, and I'm delighted to welcome you to this important webinar titled Early Action, Lasting Impact, the Investment Case for Preconception Care in Low and Middle Income Countries. Let me begin with a simple question. When does healthcare really begin for a mother and her baby? Most people would say during pregnancy, maybe at the first antenatal checkup, or maybe even during labor. But the truth is, by then, many of the most serious risks to the health of mothers and baby have already taken place. In fact, the story starts much earlier. So today, I would like to invite you to take a step back from the delivery room, back from the first antenatal visit, and back even from the moment a pregnancy begins, and ask, what if the most impactful health intervention happens before conception? That is the heart of today's conversation, preconception care, the health and social support provided to individuals and couples before pregnancy occurs. This may seem like a technical term, but it's really quite simple. It's about preparing people for healthiest possible start to parenthood, physically, emotionally, and socially. It means ensuring that girls are not forced into early marriage or female genital mutilation. It means supporting women to space their pregnancies when they are ready. It means treating anemia or diabetes before pregnancy, not during pregnancy. And it means preventing obesity and smoking before pregnancy. And it means recognizing that the health of future generation begins long before birth. And yet, despite its importance, the preconception care is often neglected. It rarely appears in health budgets. It's often missing from policies and guidelines. And in many low and middle income countries, it is no one's specific responsibilities, making it easy to overlook and underfund. But the cost of this inaction is huge, not just in life lost, but in the broader consequences for families, economics, and societies. So today's webinar is an invitation to shift our thinking. We are not just talking about saving lives. we are talking about investing in lives, about understanding the economic case for preconception care. What does it cost society not to act early? And what could we gain in health, in well-being, in economic growth if we did? So to guide us through these important questions, I'm honored to introduce our speakers and proudly my PhD student, Sebastian. Sebastian is a PhD researcher at the University of Limerick in Ireland and a global health consultant. His work brings together public health, economics, and system thinking to help us reframe preconception care as a smart investment in our future. In today's session, Sebastian will explore how investing in preconception care is not only critical for improving health outcomes for mothers and children, but also represents an economic opportunity. He will examine two questions. What does it cost not to act on preconception health? And what can we gain by acting? Thank you for joining us today, and please use the chat box to share your thoughts and questions throughout the sessions. Now it's my pleasure to hand over to you, Sebastian. So the floor is yours.
Yeah, thank you. Thank you very much, Khalifa. Good morning or good afternoon, depending on where you are located. Thank you very much for the invitation. Thank you, Judy, for the nice introduction. I'm really pleased to be here with you today. And I mean, it doesn't really matter if we don't have more people. I think what really matters is the quality of the audience, and I have good quality today. So I'm pleased to share all these insights with you. I'm also really pleased to talk about a topic that I have been working on for a few years. It's been 3-4 years that we're working on this topic with Khalifa. And this topic is the economics of preconception health and care in low and middle income countries. And as Khalifa said, that's a topic that is often overlooked in the scientific debate for two reasons. First, because the concept of preconception health and care is still relatively unknown in practice, especially in low and middle income countries, but also because the economic perspective is not always the one that we put forward when we talk about health issues. We usually prefer to focus on health costs, health benefits, and I think this is very legitimate. But we will see in this presentation that one approach, the economic approach, does not prevent the other to exist. And on the contrary, we cannot discuss the economic implications of one disease or of one risk factor without discussing first its health burden. So what are we going to cover today? So that's structure of the presentation. I divided the talk into 3 parts. In the first part, we will try to understand better the concept of preconception care, what it is. We'll also try to understand what an economic evaluation is and why at some point it is important for these two concepts to meet. In the second part of the talk, we'll dive into the economic burden of poor preconception health. And in other words, the question, as Khalifa said, is what does it cost societies and nations not to act towards preconception health? And then in the third section, we will look at the economic value of preconception care interventions. And we will use specifically 2 interventions. The first is child marriage prevention, and the second is family planning. And throughout these 2 examples, we will see that these interventions are not just good for population health from a preconception angle, but they also make sense from an economic and a societal perspective. And then we will have the Q&A session. So let's start with the basic question, what is preconception care? And if we ask WHO will tell you this: preconception care is the provision of biomedical and social health interventions to women and couples before conception occurs. It aims at improving their health status and reducing behaviors and individual and environmental factors that contribute to poor maternal and child health outcomes. Its ultimate aim is to improve maternal and child health in both the short and long terms. So I'm not sure that this definition, to be honest with you, makes things clearer. So we'll try to break down this definition, because here we have 4 key ideas that can help us better understand what preconception care is. So first, preconception care aims to, and that's the first idea, it aims to reduce risk factors that could lead to complications during pregnancy, during delivery, but also after. The second idea is that preconception care works if these risk factors are addressed before conception. The third idea, it includes a wide range of interventions. And the fourth, that is often, that we'll often forget, it involves both women and men, because we know that men's health and behaviors can also affect pregnancy-related outcomes, maternal and child health outcomes as well. So in simple terms, preconception care means getting healthy before pregnancy to optimize pregnancy-related outcomes and to give the best possible start to both the mother and the child. So now let me give you 2 quick examples to show you how preconception health works and why it really matters. So the first example is neural tube defects. So neural tube defects are a type of congenital anomaly that severely affect thousands of births every year, especially in low and middle income countries. Neural tube defects have severe, irreversible consequences for children, but it can be prevented. It can be prevented if mothers have sufficient folate levels in their bodies when they conceive. But the challenge is that the neural tube forms and closes very early in pregnancy, usually within the first 4 weeks. So most of the time, this is way before a woman knows that she's pregnant. So it means that if we wait until pregnancy is confirmed to address this issue of low folate level, we've already missed the window. And that's why, to be very effective, those interventions like folic acid supplementation or food fortification need to target women of reproductive age, just to ensure that they have enough folate levels by the time they become pregnant. The second example is adolescent pregnancy. So in many low and middle income countries, a significant number of girls become pregnant before the age of 18. I think it's around 1 in 5 girls, adolescent girls in low and middle income countries. And these pregnancies, first, they are often unplanned, and they also carry high risks for both the mother and the baby. We observe higher rates of maternal mortality, higher rates of low birth weight, premature birth, and many different complications during pregnancy, but also during delivery. The consequence, they go way beyond health. We know that adolescent mothers are more likely to drop out of school, they have fewer job opportunities, and they're also more likely to kind of perpetuate the cycle of poverty. So in this case, optimizing pregnancy outcomes is not about improving medical care or improving nutritional status. It's about delaying pregnancy until a more favorable moment. And that's preconception care too. So these are only 2 examples that show that acting before pregnancy can contribute to improved pregnancy outcomes, and by extension, of course, can also contribute to reducing maternal and child mortality and morbidity. And this applies, as you can see on the screen, to many different areas or conditions. This is a picture extracted from a report published by WHO on preconception care. So you can see all these areas in which we can apply this concept of preconception health and care. So now that we know what preconception care is, the question is to what extent preconception care is implemented in practice. And actually, it's very difficult to tell precisely because in most countries, there's no integrated or intentional, coordinated approach to preconception care. Instead, what we observe most of the time are fragmented initiatives, isolated interventions that are not labeled preconception care interventions, but nonetheless contribute to improving preconception health. But globally, the observation that we can make is that countries focus on prenatal and postnatal care, but the link to what happens before pregnancy is often missing. And that's why in 2013, and more recently 2024, WHO called for an extension of the current maternal and child continuum of care to also encompass the period before pregnancy, so the preconception period. So we know what preconception health and care are. We know that the offer is limited, fragmented in practice. So the question now is, why is that? And actually, there are plenty of reasons that can explain this limited implementation of preconception care. There is a lack of knowledge about preconception care, a lack of awareness about its potential benefits, lack of financial, human resources, competing priorities, ethical considerations, the lack of readiness in potential beneficiaries of preconception care. And to some extent, there is also lack of evidence on the effectiveness of some interventions, not all of them, but some of them. But there is one reason that is of particular interest to us, and that's the lack of evidence on the cost effectiveness or the economic value of preconception care. So it means that we don't really know whether investing in preconception care gives good value for money. And one might say it doesn't really matter. If we know it's good for health, if we know it could save lives, we should invest. Whatever the price, we should invest. And I agree with this. And I think that everybody agrees with this. But at the same time, we cannot forget that we live in a world that is complex. Resources are limited, financial resources, human resources are limited. Health systems face competing demands, non-communicable diseases, mental health, infectious diseases, climate-sensitive diseases. So we can continue the list of priorities. We have many, many priorities. And in this context, the governments, the donors, the policymakers, they need to make tough decisions, tough choices. And when they do, they need evidence. And that's where we think with Khalifa that economic evidence comes in. And economic evidence can be useful. Because if we can show that $1 invested in preconception care brings $2, $5, or even $10 in return, we make it easier for decision makers, policymakers, to prioritize and to allocate resources towards preconception care. So to make a case that resonates beyond the health sector, we need to speak the same language, the language of finance ministers, budget holders, and donors. Is there a question?
I would like to ask everyone to mute your microphone, please. Go ahead, Sebastian. I'm sorry about that.
Yeah, okay. I keep going. So that's an important point. Being able to speak the same language as the finance ministers, as I said, donors, being able to bring this economic perspective. And this is an important point, not only for preconception care, but that applies to any health issues that we want to promote and that we want to highlight. So in this discussion, we will discuss economic evidence, and we have different ways to generate economic evidence. In the presentation, I will refer to two main types of economic studies. The first is what we can call the economic impact analysis. So this type of analysis helps us understand what a disease or a risk factor costs to a society if we don't act. So for example, we can measure the economic impact of non-communicable disease through their impact on employees' productivity, through their impact on healthcare expenses, or even the cost of mortality. The second type of study is the full economic evaluation, and more specifically, we will mention cost-benefit analysis. This type of analysis compares the cost of an intervention to the economic benefits that they can bring. So a simple example, if a vaccine costs $10, but this vaccine prevents an illness that would cost $100 to treat, it means that we have a return on investment of $10 for every US dollar that we spend. So that's the purpose of a cost-benefit analysis. And these two studies will help answer the two central questions in our research work. The first is, what does it cost not to act towards preconception health? And the second, what do we gain when we act? So let's try to answer the first question. And to answer this question, that's what we can do. So first, I hope that it's clear because the font is maybe small, but I try to be as descriptive as possible. But on the left of this diagram, we have a list of 5 risk factors. We have adolescent pregnancy, we have short birth spacing, pre-pregnancy intimate partner violence, pre-pregnancy overweight and obesity, and female genital mutilation. So these 5 risk factors, they have 2 points in common. The first, they can all theoretically be eliminated or mitigated before pregnancy. And some of them can be addressed way before pregnancy. It's the case of female genital mutilation, because female genital mutilation usually occur very early in life. But the little girls who experience female genital mutilation will grow up, will become adults, some of them will become pregnant, and their pregnancy will be at higher risks because of the complications of female genital mutilation. The second point that all these 5 risk factors have in common is that they are all associated with increased risks of perinatal death, which includes stillbirth, but also neonatal death. And this relationship, as you can see on the diagram, is sometimes moderated by intermediate outcomes, such as the higher likelihood of preterm birth with or without small 4 gestational age. So the first question that we must ask is, how can we quantify the number of perinatal death attributable to these 5 preconception risk factors? And to estimate it, we can use an epidemiological tool or technique, which is called the population attributable fraction, or PAF. And I don't want to go into technical details here, but the PAF allows quantifying how much of a health outcome is caused by a specific risk factor. And we use it a lot to quantify, for example, the proportion of cancers or the proportion of cardiovascular diseases attributable to some modifiable risk factors like smoking, alcohol use, physical inactivity. So in that case, in this study, the PAF can help us understand how many and what's the proportion of the perinatal death that could be avoided in an ideal world where all these 5 risk factors would be totally eliminated. So once we estimate how many perinatal deaths are attributable to poor preconception health, the next question is, how do we put an economic value on those deaths? Because we need to put an economic value on the health benefits if we want to calculate its economic impact. Not health benefits, sorry, health implications, adverse health outcomes. And actually, there are a few ways to put an economic value on these health outcomes. We have several options. One option is to calculate the healthcare cost. So that usually consists of estimating what the healthcare system spent to treat the complications associated with a health condition or risk factors. Another approach is called the human capital approach. And in this approach, we treat each death as a loss to the future workforce. So it means that each deceased individual is a person who would have potentially worked, who would have earned income, and who would have contributed to the economy. So in that case, we estimate the value of lost productivity due to mortality. In this study, we used a third method, which is more of a societal approach. And this approach uses a key concept called the value of a statistical life, or VSL. So it's not really about putting a price on a person's life, it's about estimating what a group of people, what people in a given society are willing to invest collectively to reduce the risk of death. So it sounds technical and we don't have time to delve into all these aspects, but the idea is actually quite simple. For example, if a group of 100,000 people are each willing to pay a small amount of money, let's say $100, to reduce their personal risk of dying by a small amount, we can aggregate all this and we can determine that the society, this group of people, is willing to pay, let's say, 10 million US dollars to prevent one statistical death. So just to give you a broad idea of this concept of VSL, the VSL in the United States currently is estimated around $13 million. So that's the price that collectively people would be willing to pay to avoid one statistical death. In other countries,
Excuse me, Sebastian, 13 or 30?
13.
13.
13,
Thank you.
yeah, million, sorry.
Huh?
In other countries, it's usually lower because this calculation depends on many parameters. It depends on income levels, it depends on mortality risk perception that of course varies from one country to another, and also many other factors, but the logic is the same. Okay, so we go back to this diagram and we now have, I think we have all the necessary ingredients. We have the risk factors, we know how to estimate the proportion of perinatal death attributable to the risk factors, and we know the societal value of one perinatal death. And this is actually the approach that we used with Khalifa to calculate the economic burden of poor preconception health in 15 low and middle income countries. It's a study that is about to be published. I think it's a matter of days or weeks now, but I'll share with you some insight. I'll share with you the results of this study. So we have a first shot here. So what we can see on the vertical axis, we can see the percentage of perinatal death attributable to the 5 preconception risk factors. On the horizontal axis, we have the crude number of perinatal death associated with each risk factor, okay, with the 5 risk factors. So every dot that you can see here is one of the 15 countries that we included in this study. So on average, the results suggest that about 21% of perinatal death in those countries are attributable to poor or suboptimal preconception health in 2020. On the top left, we can see Sierra Leone, which has the highest proportion with around 35%. On the right, we can see Pakistan, which has the highest number of perinatal death associated with preconception risk factors. And this is not surprising because Pakistan has by far the larger number, the larger population and the higher number of births compared to the other countries. So the message that we want to convey here is quite simple. What we want to say is many perinatal death can be prevented through better preconception health. But I want to insist on something really important. The path is a theoretical limit. So as I said, we are saying that on average, 21% of perinatal death could be prevented if all 5 preconception risk factors were totally eliminated. And this is, of course, unlikely to happen. We cannot totally eliminate these risk factors. Adolescent pregnancies, short birth spacing, pre-pregnancy overweight and obesity. However, even a small reduction in the prevalence or incidence of these risk factors can lead to significant health benefits and reduction in perinatal mortality. So that's the health burden. So let's look at the economic implications of these figures now. So on this graph, we have the economic burden in 2020 still in international dollars. That's on the horizontal axis. On the vertical axis, this is the economic burden expressed as a percentage of the gross domestic product, the GDP. So one quick but really important note here, we usually don't express the economic burden as a share of the GDP when we calculate the economic burden using the value of a statistical life. Because when we use the value of a statistical life, we are not talking about money that government actually spend or lose. It's about how much society is willing to pay to reduce the risks of death. It's a societal cost. It's not a real budget cost. So comparing it to the GDP is not correct. So it would be wrong to say, for example, if we fix these 5 risk factors, we will recover 1.5 or 2% of the GDP. It's more complex than that. But here, we're doing it. We're doing it just to give you a sense of scale, just to help you compare all the countries, because we know that big numbers like $5 billion, $10 billion, $50 billion, that doesn't mean much to most people. So putting it in relation to the GDP just help make the comparison easier to understand. So that being said, that's the result. The total economic burden in the 15 countries is about 51 billion international dollars. And that represents the equivalent of 1.7% of the GDP on average. The highest societal losses are in Pakistan and Nigeria. And again, this is mostly due to population size and the number of births. But now if we look at the economic burden in relation to the GDP, we can see on the top left that Mali has the highest economic burden, slightly over 3% of the GDP in 2020. So now if we recap all these findings, we found 3 things. We found that about 20.7% of perinatal death in those 15 low and middle income countries were attributable to 5 preconception risk factors. This represents about 233,000 perinatal deaths, and these perinatal deaths, in turn, generate societal losses estimated at 51 billion international dollars, which is equivalent to 1.7% of the GDP in 2020. So this answers the first question, what does it cost if we don't act? And actually what we can see is that inaction towards preconception health comes with real and measurable consequences, both human, economic, and societal. So that was for the first question. So let's turn on to the second question. What do we gain now if we act? And in other words, the question would be, what's the economic value of investing in preconception care interventions? And as I said, we would use 2 examples, and we will start with child marriage prevention. So in low and middle income countries, yes, 1 in 5 girls marry before the age of 18. We know that there is a strong association between early marriage and early pregnancy. So adolescent girls are more likely to become pregnant. They have 5 times more likely to become pregnant than those who are not married. And in turn, adolescents are more likely to face complications during pregnancy. Their babies are more likely to be born too soon, they are more likely to be born too small, or they are more likely to die within the first days of life. So by preventing child marriage, we can help reduce, at the end of the day, neonatal death and stillbirth by delaying pregnancy until a most favorable moment. There's one problem, and this problem is that measuring the benefits of preventing child marriage through pregnancy-related outcomes is not something easy. Because if we want to do that, you would have to follow a large cohort of girls, and you will have to follow them for quite a long time, from adolescence to marriage, pregnancy, birth, and after. And we know that's expensive, that's complex, it takes time, and that's why we used technique, we use simulation modeling. And probably that many of you are not familiar with simulation modeling, but it's not something that complicated. To make it simple, we use real-world data on marriage, pregnancies, health risks, program effectiveness, program cost, and we use all this data from the real world to build a model that will try to reproduce the reality as best as we can. And then we run this model to see what would theoretically happen if we change some parameters. If, for example, we mimic a situation where we would be able to implement an intervention to reduce child marriage rates, and we see what happens. For this analysis, cost-benefit analysis based on simulation modeling, we used the case of Senegal as a case study. And we use Senegal for a simple reason, because we had access to relatively recent demographic and health survey in Senegal. So for us, that means up-to-date data regarding all the parameters that we needed. So again, I don't want to enter into the technicalities of the model, but the idea globally is that we create a model where we follow a cohort of girls aged 15 at the beginning of the simulation until they reach 18, so for 3 years. Every year, we know that some of the girls will die from many causes, some of them will get married, some of them will become pregnant, some pregnancies will end up in live birth, and some live birth will unfortunately lead to neonatal death. So all this is based on a set of probabilities. Age-specific, these probabilities are also adjusted based on where the girls live, because the risks are not the same in rural and urban areas, for example. So all this is based on those probabilities extracted from the demographic and health surveys. So we have a baseline scenario. That's the scenario on the left. So in this scenario, we tried to mimic the current situation in Senegal. Then we create another scenario in which we simulate the implementation of an intervention to reduce child marriage rates in rural areas. So that's the scenario in the middle. And finally, we look at the difference in terms of outcomes between both scenarios, and we can measure the impact of child marriage prevention. And this is what we found for Senegal. So the baseline column shows what would happen without any intervention. And the intervention column shows the results with a community sensitization program in place. So as you can see, this program could prevent theoretically over 7,000 child marriages, 2,500 adolescent pregnancies, and it would lead to 86 fewer neonatal deaths and 46 fewer stillbirths. So it does not seem a lot, but we have to keep in mind that this is only for one cohort of girls and for only 3 years. So now, in economic terms, this intervention would cost about $6 million to be implemented, and it would generate societal benefits valued at over $25 million. So it means that for every dollar that we invest in this intervention, in child marriage prevention, we expect an economic return of $4.2. And this makes a strong case for child marriage prevention as a smart and cost-effective investment from the preconception health perspective and the preconception care health angle, because we also know that reducing the prevalence of child marriage will also bring many other benefits to girls in terms of reducing, for example, dropout for school, creating more opportunities, job opportunities, and globally creating more autonomy for the girls. But here we are only looking at the results and the benefits from this preconception angle. So that was the first example. The second is about family planning. So in many countries, especially low and middle income countries, we have millions of women who want to avoid or delay pregnancy, but they don't have access to the means, to the resources to avoid or delay these pregnancies. This is what we call unmet need for contraception. So reducing unmet need for contraception means giving more women access to the contraceptive method that they want, but currently don't have. And this helps prevent unintended pregnancies, which in turn would reduce maternal death and child death by avoiding high-risk pregnancies and also poorly spaced pregnancies. So in our simulation, we also used Senegal as a case study, and we looked at what would happen if 80% of current unmet needs in Senegal were satisfied after 15 years of increased efforts, so from 2025 to 2040. And these are the results. So over 15 years, this investment in increasing access to family planning could prevent more than 750,000 unintended pregnancies, 35 maternal deaths, and more than 13,000 child deaths. The cost of expanding access to those services would be about $59 million in total. And as you can see, the societal benefits outweigh the cost. So just from reducing maternal death, we can expect benefits estimated at over 160 million US dollars. And from reducing child death, the benefits could even reach over $3 billion. So depending on the perspective that we take, it means that this intervention yields a benefit of 2.7 or even 51.5 US dollar for every dollar that we invest. So a quick note of caution here, because, oh, sorry, I clicked too fast. Okay. Actually, there is no global consensus yet on how we can capture the life saved in children due to family planning. So we followed an approach that is considered acceptable, and it's actually the best available. But this approach still raises questions among modelers. So we must be cautious when we present this benefit cost ratio of 51.5. However, we can be much more confident in the benefit cost ratio of 2.7, which is still high, that we can obtain from reducing maternal mortality risk, because this one was calculated based on a widely accepted and a more robust method to estimate the maternal lives saved from increasing family access to family planning. So we're coming to the end of this presentation. So just to wrap up, so we've seen different things, but globally we've seen that poor preconception health comes with serious consequences, not just in terms of health, but also in economic terms. And we have also seen that investing in preconception care through interventions like child marriage prevention and family planning can bring value for money. And I would say that this is just the beginning, because in our research, we only focused on two interventions that we used as examples. But there are actually many others that we can investigate, like nutrition, mental health, support, changing lifestyle behaviors like smoking, alcohol use in the preconception period, and gender-based violence prevention as well. And we're currently thinking with Khalifa and considering a similar analysis for female genital mutilation prevention, for example. Before finishing, I also have to be honest with some of the limitations of this study. and especially the limitations related to the use of simulation modeling, because yes, simulation modeling is a powerful tool, but it always involves some sort of uncertainty, because we have to use sometimes assumptions about behaviors, about risks, about program effectiveness, program costs, especially when we project the results over a long time. So we cannot predict exactly how all the different parameters will evolve over 10, 15 years. So that's also why we need more research to confirm these findings and to show to what extent they are context specific. And another thing that I think it's really important to mention, even though we use simulation modeling and we believe that it's a really interesting tool, I want to emphasize on the fact that simulation modeling will never replace intervention studies that we can conduct in the field. And even if it's difficult, long, and expensive, we highly need more evidence on preconception care coming from RCTs, longitudinal cohort studies, and that type of intervention studies. So just to conclude, so the key message, I think, is that if we want preconception care to be more recognized, we need to keep building the case with both the health and the economic arguments. And once again, I think this is an approach that does not apply to preconception care only. This is something that can apply to any areas of health. And I've had the opportunity to use all these methods with Khalifa in different fields, such as air pollution reduction, cancer prevention and control, nutrition, non-communicable diseases in many different contexts. And in each case, the goal of our work is to help shift this narrative that we don't spend on health, but we invest on health. And that would be my final word. Yeah. Thank you very much for your attention.
Absolutely fantastic. Thank you very much, Sebastian. Maybe you unshare your presentation, but exactly what you just said. We need to shift the narrative from spending on health to investing in health, and we need these kind of evidence to support donors, policymakers to make good decisions. Judy, how long do we have for questions and answers? Do you have 30 minutes or less?
Technically, we end at 10, but we started late. So let's go for 10 or 15 minutes, okay? Because I think there's a lot to discuss.
Exactly. So a few questions I will start with, but please, if you want to speak, if you just raise your hand, and Sebastian, we just have these questions from the audience, and one of the less discussed but critically important links is between preconception care and the growing burden of non-communicable diseases. So could you elaborate on how addressing NCD's risk factors before pregnancy, like obesity, hypertension, or diabetes, can improve outcomes for both mothers and babies? And that could be built on your causal loop diagram and conceptual thinking that you initially published.
Yes. Well, first, I would like to clarify that I'm not a physician, so I cannot go into the physiological pathways, for example. So I know for some people it's really important to understand what really happens. I'm unable to explain you exactly the relationship between NCDs and preconception care at that level. But what we know is that there are many different links between NCDs and preconception care. Khalifa mentioned overweight and obesity. We know that overweight and obesity is associated with increased risks of neonatal death, stillbirth, postpartum hemorrhage, maternal death. We know that hypertension before pregnancy is also associated with increased risks of hypertension during pregnancy and adverse health outcomes like eclampsia that can also lead to maternal death. Diabetes as well. There is increased evidence on the link between diabetes or uncontrolled diabetes before pregnancy and many different adverse health outcomes related to pregnancy, but also related to delivery. But there is also a link between preconception care and NCD that we don't think about, and the fact that when we address those risk factors, as I said before, we're looking from the preconception angle, but we have also to keep in mind that many of the interventions that we investigated will have an effect on other areas. So if we tried to reduce adverse health outcomes that can happen during pregnancy by reducing, for example, obesity and overweight, what would happen? We can improve pregnancy-related outcomes, but that will also have an impact on NCDs in general. So it's important to think that preconception care will bring additional benefits. And many of the interventions that we can include in preconception care will not limit its benefits to the preconception pathway. So the preconception pathway is only one niche, but we also have to take into consideration all the other aspects that can be improved through these interventions. So it's a two-way relationship. It goes in two directions. Yeah.
Perfect. And the spillover effect and all that. Brilliant. Judy?
So I think I don't know the last name because I couldn't see it, had his hand up first, so I'll wait.
Okay, there was another hand.
Yeah. Let me put my hand down so you can see it, and then I'll put my hand up again.
Yes.
I don't know.
So your name is not clear, but it's doctor. So please go ahead.
Right.
You
have to
are
I'm not sure
You're
if that's
us.
me. Is that me?
Yes, yeah.
Yeah.
Oh, geez, it's not supposed to be doctor. I don't know how how it got to be written like that. But anyway, thank you so much. My name is Lukanyo Nyati, and I'm in South Africa. Thank you so much for the wonderful presentation. I'm based at the University of the Western Cape in South Africa. And thank you, Sebastian, for the wonderful presentation. I was going to ask a question, but maybe just before I ask the question, just make a small comment. So I was part of a preconception study that is taking place in Johannesburg. It's looking at improving, the outcome is in the child and trying to reduce, the levels of obesity in the child, improving body composition in the child. And that's a link I think Sebastian was talking about in terms of non-communicable disease and the hypothesis was that if you improve the health of the mother during the preconception stage and obviously during pregnancy, that will ultimately have benefits for reducing, the levels of body composition in the child, and thereby reduce the risk of non-communicable diseases in later life. But one thing I can say about, these kinds of trials is how difficult it is to try and change behaviors and influence behaviors. I mean, it doesn't matter whether it's during preconception, pregnancy, or any other period, but trying to influence behaviors is very difficult. But one of the areas that it's been focusing on is just making multi-micronutrients available to young women with a hope that those will improve the fetal development and child growth outcomes. But the question that I wanted to ask was just on your second last slide that you presented, which is around the cost, the benefit cost ratio, where you said that we should be cautious in terms of our interpretation of the results. And you mentioned something about, I think this was around reducing child mortality, and you mentioned something around mothers concerns that were raised by mothers. And I just wanted you to expand on that, if you could, please. Thank you so much.
Yeah.
Thank you very much. Sebastian, I will take few questions and then,
Yeah.
I will ask you so we can save. So if you can just take notes. Judy?
Okay. So first of all, thank you very much for a very comprehensive look at some of these issues and very complicated analysis. I think this is really important work. My question is, once we have this kind of information, I mean, how are we going to address the issues? Because now there's data, and our last webinar was about postpartum hemorrhage and really moving from having some data to implementing policy. And so, well, many of these things have to do with behavior. Many of the others have to do with policy. And this is a government-oriented, data-driven project to me. And when you talk about things like preventing child marriage, it requires more than any one sector. It requires laws, it requires enforcement of laws, it involves involving community leaders. So I'm wondering how you see all of this coming together in the future to change the outcomes. Because you have an intervention, but then implementing an intervention is not always easy.
Thank you very much, Judy. Surika, you had few questions in the chat. Do you want to maybe to
No,
ask?
think I had invited one nutritional specialist expert, Dr. Shweta Khandelwal. She is working, her work is on nutrition and how it affects preconception care. But she put some trials, she inserted some links also for the publication, like the PRIA trial and a few more publications, but she had to leave. And I just wanted to share that when we have such kind of data, like Judy said, we really need to work on advocacy, advocacy towards the further transformation will come only when there is an intersectorial approach, and the main stakeholders are the government. So in India, we have started one project which is called as the Sampurna Preconception Care Project. Specifically, we are working on advocacy with the various organizations like CIHF. We are having JPIGO and UNICEF in this project. And mostly we need to create awareness not only amongst the community, but also the healthcare workers. The healthcare workers themselves are not aware, of how and we should be giving the preconception care and the value of preconception care. So that project I wanted Dr. Shweta also to discuss with you. But overall, I think the statistics which you have presented is mind-boggling. Only 2 interventions you have narrated, and there are so many, which one of them is, of course, nutrition and interventions like folic acid. And even in our country, we have hypothyroidism is so common. Almost 17 to 19% of our women who are pregnant women are hypothyroid. So even finding out simply the numbers like what is your hemoglobin, what is your weight, what is your blood pressure, even simple knowledge of simple things can lead to very interventions which can benefit as far as the cost benefit analysis you've done. So that is all from my side.
Thank you very much, Sureka. So because of the time, I will hand it to you now, Sebastian, to address this comment, and then we will conclude.
Yeah, okay. So the first question was about the benefit cost ratio and the difference between the 2 benefit cost ratios that we presented. Well, in our simulation modeling, when we increased the percentage of current unmet needs satisfied, we have 2 outcomes. We have a reduction in child mortality, and we have a reduction in maternal mortality. And the methods to estimate both is different. We didn't use the same approach to calculate that. So what I was saying is, for the maternal death prevented through family planning, we used a robust and widely accepted methodology. For estimating now the number of child deaths averted through family planning, we used an approach that, as I said, is acceptable, is the best that we can use, but it's an approach that is still under discussion, especially around people working and using those type of models. So that's why instead of trying to merge the maternal death prevented and the child death prevented and calculate the economic benefits that we can get from both, we decided to disaggregate. So we have two results. We have a benefit cost ratio where we used the cost of the intervention in relation to the benefits obtained from reducing maternal death. And this is the benefit cost ratio of 2.7. And we have a second benefit cost ratio where we used the cost of the intervention and the benefits obtained from reducing child death. And this is the cost benefit ratio of 51.5. We need to be careful with this cost benefit ratio of 51.5 because I believe the method is probably not robust enough to draw strong conclusions. So that's why I put this value on the slide, but I want to attract your attention on the cost-benefit ratio of 2.7 through the reduction of maternal mortality. So I hope it clarifies things.
Perfect. And then the comment from Judy as well regarding the policy.
That's a tough one. This one is really difficult because that's what we are trying to do with Khalifa. It's been 4 years working on different investment cases in many different areas. And the question is always, what can we do now with all this evidence? But I would say that there is a difference between this investment case and preconception care and the others. Because for the others, we worked on health issues that are well recognized. We don't have to present non-communicable diseases. We don't have to explain what air pollution is or cancer. We all know what it is. So we can jump to the conclusions. For preconception care, I would say that our approach is different. What we tried to do and our modest contribution to the growing evidence on the economics of preconception care is just making preconception care visible. We just want to show that sometimes there are some interventions that we know these interventions, we know that child marriage can bring benefits, but do we know exactly that child marriage prevention can also affect pregnancy-related outcomes, and that preventing child marriage can also reduce and contribute to the reduction of child mortality and morbidity? So that's what we try to do. I would say preconception care is relatively new, so the first step is to make it visible, and then how can we have access to policymakers to change the narrative? Unfortunately, I think that's just the beginning. It will take some time, but we have to improve our understanding of preconception health and care first.
Sebastian, thank you very much. I'm really enjoyed this, and I'm sure that all the participants, we are opening their, thinking around shifting our thinking as well. I would like to thank also the Women in Health Together for the Future for hosting this, webinar and many other webinars in an attempt to improve women and health and provide evidence in this area. This webinar is recorded, and we will be sharing the recording with the participants. And Sebastian, you might also want to share the publication that you publish from this project, and please do share your emails so to receive the certificate for attendance of this webinar. Thank you very much. Back to you, Judy, to formally conclude from your side.
Well, I would like to thank you both very much. I think this was a very stimulating and thoughtful presentation, and we clearly have a lot of work to do. So thank you for providing us with some of the evidence that we need to do it, and thank you all for joining us. And there's a way to join us if you're new to this call. In the chat is the link to our website, which is w24f.org. So thank you all very much, and have a nice rest of your day, however long that is. Thank you. Bye,
Thank you.
everyone.
Bye.
Thank you very much. Thank you.
Thank
Bye.
you. Thank you, Khalifa and Sebastian. Thank you, everybody.
Thank
Sebastian,
you.
Thank you.
Thank you. It's very fruitful. Yeah.
Thank you.
Thank you. Bye-bye.
देखिए इस वक्त हम यहाँ सनातन यहाँ से उतरते हुए हम पहुंचेंगे फिर वहां से बाहर निकलकर हम साउथ